I really want to welcome everybody to this wonderful event. I have the honor to introduce Dr. De Groot. He's one of my colleagues. He is the Division Chief of Neuro-Oncology at UCSF, really an internationally recognized leader in the field, especially with brain tumor treatments of all kinds. And he brings a really wealth of knowledge and experience and compassion really to his work. We're incredibly fortunate to have him here tonight with us. So during the presentation, Dr. De Groot will be offering some highlights from the recent Society of Neuro-Oncology. This is our flagship society for which we all participate. It's a multidisciplinary society. And the meeting that we have every year is really one that's so exciting because it's so hopeful of all of the work, the hard work that the researchers are doing in terms of understanding the brain tumor biology and all the clinical research that's happening to advance the care of our patients, but also to focus on quality of life as well. So it's a really wonderful time for us as people involved in taking care of patients to really come together and network and learn from each other. This webinar is proudly sponsored by the Sherry Sobrato Brain Cancer Survivorship Program, and we really look forward to having you all listen and also ask questions. So once again, thank you all so much for being here tonight, and I'd like to turn it over now to Dr. De Groot.
Great. Thank you very much for the kind introduction and for the invitation to present today. I think I did this last year. I did do this last year, and it was really quite a bit of fun. So I'm going to try and do my best to provide an update on the 2025 Society for Neuro-Oncology meeting. It's great to see a lot of familiar faces, but also to see a lot of people I don't know. So this is very exciting. I am going to go ahead and share my screen. Hopefully that looks okay. So Naomi and Dr. Chang asked me to do this again this year, and I have to say it's really quite a daunting task. There were something like 3,000 people at the meeting this year, which is kind of a record. And there were thousands of abstracts and presentations presented over the course of the 4-day meeting. So it's always kind of a question of what is the most important, what's the most impactful. And so some of this is like my perspective on that, but also to try and be as sort of comprehensive as I can as well. So with that, I'll get started, give you my disclosures for groups that I consult with. And here is the outline. Now, it's kind of it's a long outline as I was like realizing, oh, wait a minute, I want to show something about this. Some of these updates are actually relatively short, though, just more high level. And then others I go into a lot more detail. So one of the things obviously we're really interested in is some of the highlights from the clinical trials that were presented. There continues to be a lot of research on lower grade glioma. So these are the IDH mutant tumors. And so there's a lot of excitement about that. I did take the liberty of inserting a new update that came in December that was not presented at the SNO meeting, but I figured there might be some people that are interested and will ask me questions about it anyway. So I'm going to provide that update. There's a little bit of kind of background on tumor biology and sort of more basic concepts. Obviously, AI is like one of the super hot topics, and there's a lot of AI being presented at SNO, so I'll give some high level updates of that as well, and then talk a little bit about immunotherapy, liquid biopsies, some surgical innovations, and then briefly about disparities research. So lots to cover, some in more detail than others. So this is, I think I presented this last year as well. This is just a really very basic overview of how we diagnose patients with primary brain tumors, predominantly those with diffuse glioma. And I bring this up again just to, emphasize the importance, number one, that, having molecular testing is critical for how we treat patients, but also to highlight how IDH mutation is really central as kind of like the very first step in this diagnosis. So IDH mutation is one of the very first tests that we do on the tissue. And if, of course, as you know, if it's not mutated, then it's sort of more likely to be an IDH wild type diffuse glioma, which would most likely be glioblastoma, although not always. And then if it is IDH mutant, then it would either be an astrocytoma or an oligodendroglioma, and these are some of the molecular characteristics that are associated with that, and some of the histologic characteristics associated with something that might be a grade 2 tumor versus something that might be a grade 3 tumor. So again, there won't be a test at the end of this presentation, um, but this is, I think, just kind of important kind of re-review for some background on the types of tumors that I'm going to be talking about. So one of the updates from SNO, well, these three updates here that I'm going to talk a little bit more about. So one of them is the phase 3 Stellar trial. And this was a sort of an update of some results that were presented previously. There is been some discussion about tumor volume changes and what's called tumor growth rate. And so looking at that data and how it might impact how we treat patients. And this is data that came from the Indigo trial that was published a couple of years ago, and led to the approval of vorasidenib for IDH mutant grade 2 tumors. And then within the same kind of topic, there were some presentations or a presentation about sort of the impact of IDH mutation on some of the immunologic factors in primary brain tumors. So that's another really interesting study that I'll present. Okay, so not to go into too much detail, but the Stellar trial evaluated a new drug. Actually, it's a really old drug, but it was new in terms of an entry into a randomized phase 3 trial of eflornithine. So eflornithine is a drug that inhibits some of the building blocks that are required for tumor cells to maintain their integrity and to grow. And so this drug would potentially block those building blocks from being formed by inhibiting this enzyme called ornithine decarboxylase. And in that situation, the tumor would not be able to grow, and so would die. This concept actually came from Dr. Victor Levin, who used to be at UCSF. I met him at MD Anderson, and he was really very much of a pioneer. In fact, we even have a lecture named after him at the annual SNO meeting, the Victor Levin lecture, just to recognize his contributions to the field. But anyway, this study, the schema that is shown here, was to evaluate this new drug together with lomustine, a drug that is commonly used in these types of tumors, compared to just lomustine by itself. And this was really only to evaluate this in patients with anaplastic astrocytoma. This study started using the 2016 WHO criteria. So that very first slide that I showed you with all of the different boxes and the different important molecular factors, that's based on the World Health Organization 2021 criteria. So this comes out every 6 years. And this particular clinical trial actually used earlier criteria, and it wasn't necessarily evaluated in only patients that had IDH mutation. And it was really just if the patient had what was being called an anaplastic astrocytoma, that was enough of the criterion to be enrolled into the trial. And so, unfortunately, the trial, because it enrolled patients that did not have the IDH mutation, actually was essentially technically negative. And so this plot here on the upper right-hand curve, this is what we call a Kaplan-Meier curve, and this is sort of the survival of patients over time. And you can see these two curves basically overlap. They're the same curve essentially, and so there's no difference between the two different groups. But if you use the new World Health Organization 2021 criteria, which is what we use today, and that's how we enroll patients in our trials today, you actually see that the drug combination worked, and it worked very significantly. It led to much longer survival, less risk of death, and so it was really potentially very impactful. So the combination was effective, and there was a very clear benefit in those patients with IDH mutant grade 3 astrocytoma. And of course, this is, as you know, we don't have very many positive trials, so this is I think very, very exciting. Um, and it also demonstrates that molecular stratification, that very first slide, is so critical in terms of how we specifically treat individual patients, and how we enroll them into trials and all of that. I think one of the challenges now is that the analysis that I showed you where there was a benefit is unfortunately not how the trial was originally designed. And because of that, it may be very difficult for the company to get approval for this drug combination to actually treat patients. I know they're in ongoing discussions to see if they are able to do that. But the way typically approvals are granted is, if you demonstrate a benefit using the criteria that you used originally to design the trial. So you can't go back and kind of change how you analyze the data. But in this case, the new analysis is really based on advances that we've made in the classification of brain tumors. So I think there's a good argument to allow this to go through, but I think there are some potential hurdles. There were a couple of other very interesting novel therapeutic approaches. One of them was a mitochondrial target. So this is targeting sort of the energy centers in the cell. So tumor cells and actually all of our cells can live on either glucose, or they can generating energy substrates through our mitochondria. And so this particular trial was looking at whether or not this drug could inhibit energy production in this cell, this part of the cell in the mitochondria, and in doing so, sort of reverse the Warburg effect. So they use this coenzyme Q10 lipid nanodispersion and gave it together with sort of standard of care. And they saw some very interesting benefits, and it was seen in both patients with MGMT promoter methylation and those that were unmethylated. So it benefit extended across all different tumor subtypes. And so that will probably be going forward in a larger study. There was another study presented by Andrew Brenner, who was a medical oncologist in Texas. And they used a type of local radiation delivery. So rhenium-186 is a type of radiation. It was given directly into the tumor with a technique called convection-enhanced delivery, where a catheter is inserted and then the radiotherapeutic is sort of dispersed into the tumor. And they have done quite a bit of work, and they have very good safety profile, but phase 2 data suggested some benefit, but very early, and also needs to be sort of confirmed in larger studies. So I wanted to go back to the IDH mutation story, because I want to present a couple of updates on the IDH mutant Indigo trial. So just to briefly remind everyone that all of our cells have normal IDH1 and IDH2. It stands for isocitrate dehydrogenase. Again, there won't be a test. This is just a normal part of our cells as they are used to generate energy. And in the case of IDH mutations, it's actually a mutation that leads to overexpression or overactivation of the enzyme and creates what's called 2-HG. And The only thing to know about this is a molecule that we can measure. We can even use imaging to identify this. And it builds up in tumor cells and it contributes to the tumor cell growth. And so when we use an IDH inhibitor, we're actually able to block that 2-HG production. And that's one of the reasons why we've been able to demonstrate that these IDH inhibitors are actually effective. This is a lot of words. I think I'm going to skip this slide. It's really basically kind of a summary of what I presented at the very beginning, which is that IDH1 and IDH2 mutations are part of the classification for lower grade glioma. And there are other molecular features that help us to distinguish between what is an astrocytoma and what's an oligodendroglioma. So it used to be that the way we would treat these types of tumors would be, maximal safe resection, obviously, is the first step. And then if it was a grade 2 oligo or grade 2 astro, there was sort of a choice of just observing or actually going full court press with radiation and chemotherapy. And it was really that the opportunity where those patients that were being observed, they were able to implement and perform the Indigo trial, which I'm sure you all have heard about through other presenters like Dr. Taylor. But this is just kind of a reminder of what this study looked like. And this was, for patients with grade 2 oligo or astro who only had surgery and then were randomized to either placebo or to vorasidenib. And that, created what ended up being a very, very significant improvement in progression-free survival in those patients treated with the Vora compared to placebo. This one figure is what helped to get this drug approved back, a year and a half ago. So really, really important data. Not to go into this too much, this is what we call a forest plot. And basically, this just looks at subgroups of patients on that clinical trial, based on their age less than 40 or over 65, their sex, male or female, where they lived, the location of the tumor, et cetera, et cetera. And basically, the way to look at this is that if there's any of the lines and the dots are on the left side, that means that, the vorasidenib did better than the placebo. And as you can see, pretty much all the different subgroups actually had a benefit from this. So it's really really impactful across all different patient subgroups. This was the other endpoint of that trial. You may also remember this, which is the time to the next intervention, whether it's surgery, radiation, or to a different type of therapy. And so those patients on the vorasidenib had a much longer time until they needed some other treatment. And that was seen in both oligodendroglioma and astrocytoma. I'd say sort of more impactfully in the oligo group than the astro, just based on how you look at that line being very, very flat and not many of those patients needing something else. So going back to SNO, there were a couple of interesting presentations there one on vorasidenib. So this was real world data presented by the group at Duke, looking at sort of patients in the community. So this is not patients treated on the clinical trial, but those patients who, are in their cancer center, their local clinic, wherever, getting treated with vorasidenib. And they looked at over 500 patients, and a very large number of patients were started on treatment with vorasidenib within 3 months of diagnosis. So very, very quickly. As I mentioned, the clinical trial required that you had to be at least 1 year from the time of diagnosis. But in the real world, people are starting it much earlier. About 40% of them had not received any other treatment. So again, that's very similar to the way the trial was. But then another 40% actually were getting in a second line therapy, meaning that they had received something previously and then now we're going on the vorasidenib. On the right-hand side, this is safusidenib. So it's kind of a mouthful, but this is another IDH inhibitor It's actually only an IDH1 inhibitor. It's from a company called Nuvation, and they bought the drug from Daiichi Sankyo in Japan. So the early data from this trial is from a Japanese study looking at patients who had not received any treatment but had IDH1 mutation. And I know this data really well. They had really remarkable responses in those patients and very well tolerated. They did a very specific clinical trial where they were able to treat the patients before surgery and then able to look at levels of 2-HG, that oncometabolite, the problem metabolite. And they were able to demonstrate that the drug really dropped those levels quite significantly. So take home here is that really with the approval of vorasidenib, it's very rapidly being integrated into routine clinical practice and real world data showing it's being used in both newly diagnosed and in previously treated patients. So I think it's really good that people are considering this now as sort of the go-to first line therapy as opposed to what used to be the case, which was everybody was just automatically moved toward radiation and chemotherapy, which we know can really cause major decrements in quality of life. So the other really interesting abstract presented related to the Indigo trial was this concept of tumor growth rate. So I think you've all probably looked at MRI scans, and we really think about we typically do measurements on the MRI scan in two dimensions. So we find the largest area and we basically put crosshairs on it and measure those two dimensions, and then we sort of follow that over time. And you can kind of see on these images on the left here, putting two dimensions on some of these can be a little bit problematic. So there has been more and more of an interest in looking at tumor volumes, and then also looking at how can you look for early changes in volume if you're not seeing something shrink down rapidly and just go from something really large to something that you can barely see, which is not a common occurrence in our treatment of primary brain tumors. So the idea was to look at tumor growth rate, meaning can you actually slow down the tumor growth? And if you can do that, can you actually measure that? And I have to say, as we all know, sitting in clinic looking at images, sometimes it's really hard to tell whether something is stable or decreasing. And so a lot of this is being done actually with AI, we'll talk about later. But also there are ways of looking at the volume. So it's kind of the three-dimensional aspect of these tumors. And so this is a paper from many years ago, but even before the Indigo trial was published. But some of the sort of seminal work to think about how do you look at growth rate change over time. And so these graphs are basically showing theoretical changes that could occur, right? So if you look at this very top bar in the red, you see it sort of escalating. So this is tumor over time getting larger and larger and larger, almost kind of in an exponential way. And then in the green is sort of after treatment, and you can see this is the growth rate actually is decreasing. And so you can imagine multiple scenarios where that's happening, or there's basically no change, but it's also not growing, right? Which is also encouraging. So Ben Ellingson is an imaging scientist at UCLA, and he has gone through and looked at all of the patients on that Indigo trial and was able to basically show that the vorasidenib reduced the tumor growth rate in those patients compared with a placebo. And I'll show you an image of that next. And he was also able to show that this changing growth rate could actually predict sort of outcome. And that is sort of means it could be like an early predictor of how somebody's going to do on some of these drugs. Because as you all know as well, sometimes, in the first 3 to 6 months, you're really not sure how much of an impact you're having. And sometimes that takes a little bit longer. So this is what that data looks like. I'm not actually sure how I got this slide. It was on the internet somewhere. But this is what we're talking about. So the upper line that's in gray here are those patients treated on the placebo, and you can see that the volume change from baseline is just getting bigger and bigger and bigger and bigger and bigger, whereas the volume change in those patients treated with vorasidenib is actually getting much much slower. So the tumor growth rate and placebo is getting bigger by 15%, whereas in the vorasidenib group, on average, was decreasing by 1.5% or so over that time period. So very, very interesting and very exciting sort of next step. So also, as it relates to IDH inhibitors, one of the things that we know is that tumors that are either grade 3 or those that are enhancing, so those that light up on the MRI scan after contrast is given, those groups don't tend to benefit as much. So are very unlikely to have an imaging response, and the progression-free survival, the time until the tumor starts to grow again is quite short, 3.5 months. So one of the questions has always been is this IDH mutation, and specifically this oncometabolite 2HG, does it cause immunosuppression? And, is resistance to vorasidenib, as you see over here in the enhancing glioma, is that related somehow to this immune suppression? So same graph, but on the right-hand side is a little bit of additional information as it relates to the immune system. So we do actually know now that 2HG is very immunosuppressive. It inhibits the attraction of T cells into the tumor. It keeps them from growing and being active. And T cells are the cells that would attack a tumor and kill the tumor. And it limits the effectiveness of our innate immune system. So sort of the immune cells that are important for killing off foreign objects, so like NK cells, natural killer cells, or macrophages. So there's really good evidence now that is actually the case. And a group out of Germany did a very nice study. It's small numbers of patients, but actually wanted to look at whether or not using an IDH inhibitor could actually enhance the immune system and make it more active and more able to attack the tumor. And in fact, that's exactly what they showed, that IDH inhibition was associated with expansion of these CD8 effector T cells. Again, so those are the T cells that are attacking the tumor and potentially killing it. So very interesting and very exciting, and brings us to just say, yes, 2HG and IDH mutation does impact the immune system. IDH inhibitors can potentially overcome that suppression. And since immunotherapy hasn't really worked all that well for brain tumors, using this together with other types of immunotherapy actually could be an effective combination. And so UCSF and maybe a dozen or so other centers across the country are actually participating in a clinical trial that's sponsored by Servier, the people that make vorasidenib, where they're actually looking at that combination of vorasidenib to inhibit IDH together with the immunotherapy pembrolizumab. And this is the trial schema. So, patients get either the combo, the vorasidenib alone, or nothing before surgery. And then after surgery, everybody gets everything, both drugs. And I believe actually that this trial just finished accrual. So hopefully by next SNO, we'll actually have some answers as to whether or not this new combination is better than just the vorasidenib alone. So this is just a little bit of a summary in terms of clinical context. It's FDA, Vora is FDA approved. It's been rapidly adopted into the community. We know that now that tumor growth rate, or TGR, is a reliable surrogate of tumor response and outcome to that therapy. And then, obviously the combination with immunotherapy under investigation, but we're getting close to getting some answers on that. There remain a lot of unanswered questions about how to use IDH inhibitors in patients with glioma. What's the right time for that? Should you start immediately? Should you wait a year? Should you wait until you see something changing on the MRI scan? Kind of wondering, what are the resistance mechanisms? How do you monitor these things? Should you use a liquid biopsy? Can you use specific MRI techniques? How would this integrate with what would be our traditional radiation chemotherapy? Obviously, we don't need those treatments and we're not going to give them, but that's something that also has to be taken into account in terms of coordinating all those efforts. And then combination strategies. So we talked about immunotherapy, but there are other types of drugs that we use that might be able to help make that vorasidenib more effective. So again, IDH inhibition is becoming disease modifying and is not just cytostatic. I would also say I didn't present this data, but there are a couple of other benefits that we didn't talk about. One is seizures. So Vora was associated with like a 60-70% decrease in seizure frequency in patients on the treatment compared to placebo. So that's also a potential benefit there. And then there are also quality of life benefits that were observed. Again, you can imagine, not having seizures and having less tumor burden could definitely lead to an improvement in quality of life. It would be really great to compare quality of life to patients who went and received radiation and chemotherapy, but that data we don't have in a head-to-head comparison. So this is the update that's not from SNO, but I wanted to just present this briefly. I actually think I did present this last year to this group. So this is a drug called IGV-001. This is a autologous cell immunotherapy, and it was evaluated in newly diagnosed glioblastoma. And I think last time I just presented, the fact that the trial was underway and that it was deemed to be safe, but we actually have a little bit of outcomes data to share. So this is the basic overview of this treatment. So it's a personalized therapy, and it uses a patient's own glioblastoma, which is then placed into a chamber, and that chamber is actually put into the patient's abdomen. And the idea here is that the tumor is a foreign material. The tumor is not alive, of course, but the tumor is in this chamber and can elicit a systemic immune response, basically. And then the idea is that the immune response that you generate in your body can then travel into the brain and, kill the tumor cells. So yeah, this is really complicated. I don't think we really need to go into this, but it's basically patients with newly diagnosed glioblastoma. They have the surgery, they get randomized, and then they either receive, this IGV or a placebo. And the chambers are inserted, and then patients undergo sort of standard of care treatment, and then continue to have follow-up. So it's pretty well, standardized. Just the addition of this immunotherapy to standard of care. So I think probably the graph on the right might be what we presented last time, phase 1B. So that's really kind of a safety analysis. Just how safe is it? It seems to be very safe. There's some mild adverse events, particularly as it relates to where the chambers were placed in the abdomen, but no life-threatening adverse events. And then they again compared this to sort of historical control, and in their study, survival was 22 months compared to 10 months. And so what is new is that in December, the company released a press release demonstrating that patients lived significantly longer in the group that received the treatment compared to those that were received the placebo. So all 99 patients with newly diagnosed were enrolled. And I think I have the data here. Yeah, so this is the results in Word format because we don't have this hasn't been published yet, so we're not able to really scrutinize and see what's going on. But the median survival for patients treated with this therapy was 20 months compared to 14 months in the placebo arm. So this was a very significant difference. And the challenge with this is that there were only 100 patients in the study, and it was not really adequately powered to feel really confident that that survival difference is actually really different. So the company is going to go to FDA and see if they can get this approved based on this data. We'll have to see most drugs and new therapies have to be proven to be effective in a phase 3 trial, but obviously we need more treatments for our disease. So this might be something that the FDA will consider very seriously. So to go a little bit more detailed in terms of tumor biology, there were some very interesting studies looking at how are tumors able to become more tumorigenic, more like a tumor, and sort of overcome any types of barriers to tumor growth. And there's some, as Dr. Chang was mentioning, there's just so many smart people at this meeting coming up with really novel ideas about how tumors can be so creative at, making it harder for us to treat them. So these are just a couple of examples of that. So one of the concepts here is that as the authors presented, they talk about pacemaker cells in the tumor. So these pacemaker cells have sort of a rhythm that they go through in terms of the communication and interactions with those cells that are around them and with various electrical signals that actually help to promote the tumor growth. And I'm not going to really talk about this, but all of the cells of our body and tumor cells included have a lot of these channels through which various electrolytes can pass through. So we all hear about calcium and potassium and chloride and even water channels. And what has been proposed is that multiple of these sort of pacemaker cells, which might only be about 5% of the cells, increase the expression of all of these different channels, including the water channel that we talked about, which then can increase calcium signal, which then sort of sets off this like pacemaker-like characteristic where it's kind of pushing the tumor cells around it to grow faster and faster. And these authors demonstrated that you could inhibit all of these different pacemaker cells with various drugs that are approved and actually lower some of those key drivers of tumor growth. So very interesting concept that I certainly wasn't super aware of until they presented this. So it's a new idea. It's a druggable target and a potential vulnerability to disrupt these tumor networks and alter the calcium dependent signaling and tumor growth. So this is a potential opportunity to maybe overcome tumor cell resistance. So one of the other ones was looking at the glioblastoma ecosystem. So sort of, what is existing within the environment of the tumor. You may have heard this, but when we think about glioblastoma, for example, only about half of the tumor mass is actually tumor cells. The other half are a bunch of immune cells and various other cells. And so that's kind of like the ecosystem that we're sort of talking about. And really, it's important to understand what cells are in that ecosystem, what are they doing, how do they interacting with the cancer cells? Because we always think, it's all cancer, but it's actually not all cancer cells. There's a lot of other things in there. And so there's been a lot of effort looking at this and looking at patients when they're first diagnosed and then they get treated and then have surgery again. And then you can kind of compare tumor tissue from the very initial diagnosis recurrence. And so some very interesting results from this type of study. One is that at the time of recurrence, there were actually less malignant cells, but there were a lot more other types of cells, so non-malignant cells in the tumor microenvironment. Unfortunately, there was no real uniform evolution over time. So there was a lot of heterogeneity, differences in what happens over time from patient to patient. And so that, of course, makes it difficult to identify like a single treatment for all patients. It really kind of makes us think that we have to be much more personalized in our treatment decisions based on some of these very tumor specific, patient specific changes that are occurring. I found the paper for this particular abstract, so it has been published, and this is, I think, just kind of a very high level overview. On the left-hand side are the pre-treated tumors, on the right are the post-treated tumors. And really you're just seeing that, the composition of the tumor can change and there's fewer malignant tumor cells. Some of the states within the tumor are very similar. One of the findings that they identified was that those tumors that are MGMT methylated tended to have reduced methylation signature at the time of recurrence as well. So anyway, not to go into a lot of detail, just a lot of interesting findings by looking over time, and again showing that there's a lot of reprogramming in the tumor ecosystem, and these trajectories are enriched in subsets of patients, and there is some association with the treatment that they received, but also the molecular characteristics such as MGMT. So it's dynamic, it's patient specific, it's nonlinear. This is a challenge, and I think these types of studies kind of help us to open our eyes and think, okay, well, we need to stop thinking that all patients are the same, right? And really that idea of a more personalized approach to all patients. This other abstract I thought was really, really interesting, and it talks about axonal injury as a possible driver of tumor progression. And so this is very interesting. So we know as tumors grow, they can actually push on or grow into really important parts of the brain that controls specific neurologic function. And one of the things that it can do is it can injure axons. And axons are the nerves, basically, that bring the information from our brains to other parts of the body. And so they're asking, can this axonal injury, this nerve injury, actually promote tumor progression? And so in this particular case, they did study primarily in mouse models, but also looked at some human tissue, and we're able to identify some very specific mechanisms by which this axonal injury could occur. And as we know and always kind of think about, tumor cells can infiltrate into the white matter and cause nerve damage. And that nerve damage itself can increase inflammation and it can increase tumor proliferation. And in their particular study, they actually identified that if you could block those nerves from degenerating, that you could actually reduce the progression and prolong survival of the mice and also preserve the neurologic function. So it's kind of a very different way of approaching, brain tumors, which is, could you give a drug that could actually prevent this kind of damage from occurring? Again, really, really innovative idea. And hopefully we can see this, move into patients in the future. Also found this article. It had been published in Nature at the end of last year. So again, just kind of demonstrating this concept of the axonal injury accelerating tumor growth, and you can even see that here that those tumors that had axonal growth actually the survival was shorter. So very, very interesting. And in their studies, they found it was dependent on a very specific degeneration pathway, and that there were some drugs to block that, in these preclinical models, not in patients yet, but able to preserve neuronal function, improve quality of life, and slow tumor progression. So very, very interesting. Okay, so I wanted to switch gears and just briefly talk about PARP inhibitors, and this has to do a little bit with some of the interest in artificial intelligence and how AI is now starting to impact our field and ways in which it can do that. So I think we talked about this last year too. Actually, PARP is an enzyme in a tumor cells that repairs DNA damage. So we know that radiation and chemotherapy kill tumor cells by damaging DNA. But these PARP inhibitors actually can reverse that damage and then the cell survives. So there's a lot of interest in inhibiting PARP to make our radiation chemotherapy more effective. And so, this is the challenges that we have now, which has to do with number one, drugs have limited brain penetration, so we know that's an issue. We know that the way some of these drugs are designed is that they may get inactivated or they may get pushed out of the brain, or there may just be resistance to those kinds of treatments. And then, of course, we also know that there can be a lot of toxicity with these drugs, and particularly when they're given with other DNA damaging agents like temozolomide and radiation. So what I thought was really fascinating is that there were multiple studies that were using AI to develop new drugs. And so they've designed a couple of new drugs. One is a ATR inhibitor, so it's kind of similar to PARP, and then it repairs DNA damage. And we're able to demonstrate that some of these drugs could overcome some of those barriers that I just mentioned. So one thing, of course, is designing drugs that can cross the blood-brain barrier, because if you can't get to the target, then it's not going to be effective. And then to also hit some of those key survival pathways. And it really feels like AI is kind of accelerating that process. There were a bunch of AI abstracts at SNO. And so just to sort of talk a little bit about how AI sort of can be integrated. One is, the input here. A lot of it now is MRI scan and other types of imaging. There's pathology. So basically, you can take a picture, a digital photograph of the pathology as another important input, and then of course all of the molecular data and the UC 500 data, et cetera, et cetera. And then there's a lot of AI modeling that goes into this, think ChatGPT or Claude AI or your favorite. And then, what could that be potentially used to? It could improve the diagnosis. It could improve sort of identification of who's at higher risk of tumor progression. Could it actually help us to predict who's going to respond to which drug? And then also can really help us sort of guide patients towards the best treatments, wherever they might be, not just, at your home center. So there was a study looking at predicting radiation necrosis. So again, this is using very specific MRI techniques and using AI models, and we're able to identify signatures of radiation necrosis. Here at UCSF, we use a lot of PET to do that, but this used some very interesting, AI approaches to use it with just conventional MRI scans. So it's important because, as we all know, if you can identify, what's tumor, what's necrosis, that could really changes how you might actually treat the patient. So, really critical. As I mentioned, there's also approaches to predict the tumor. The tumor type is one way, but also to look at preoperative risk stratification of different tumor types. And this one was looking at meningioma before surgery and basically comparing, the MRI scan and this specialized artificial intelligence technique to see whether or not that could actually predict what type of meningioma that was, grade 1, grade 2, grade 3. And they were able to demonstrate in this study very high accuracy. It's like 93% accurate in terms of predicting what that tumor was going to be like after, on the final pathology. Um, and then there were multiple other abstracts, again, using AI driven segmentation. So we talked about this earlier when we were talking about three-dimensional volume or volumetrics, from the Indigo trial and looking at tumor growth rate. So there are AI tools that can allow you to basically automatically segment out of the MRI scan that tumor in 3 dimensions. So it can do it and can do it very, very fast. They're getting more and more accurate as time goes on, and that keeps the radiologist or the scientist from having to draw a line around where the tumor is and then to do that on multiple different slices. So this really speeds up, I think, how we can derive a lot of this information and use that information for many, many other purposes. As I mentioned, it can be used for response prediction, and then radiogenomics, which is using MRI scan to predict what genetic alterations are in the tumor. It's very, very exciting. It's moving very, very rapidly, and all of this can be coming to our clinics faster than we had actually anticipated. And these are important for a lot of reasons. Can we improve tumor classification? Right now we have our neuropathologists and we have the UC 500. Could we actually look at the heterogeneity within the tumor? I mentioned the fact that 50% of the bulk of a tumor could be immune cells, and 50% is tumor cells. Could we use that as a way to AI as a way to sort of figure out what some of those things, and then use imaging for more than just is it bigger or is it smaller? A couple of immunotherapy studies to mention. There was a trial looking at actually, I think this is a preclinical study looking at two immune checkpoint inhibitors. So PD-L1, that's the pembrolizumab or nivolumab. And then there's another checkpoint called B7H3. And I just wanted to put this in here. I'm not going to go through this in a lot of detail. This image on the left here sort of describes why immunotherapy has really been a challenge in our field to make it effective. And some of those things that we've talked about, there aren't very many T cells in there. There's a lot of macrophages in the tumor, and the tumor cells themselves don't have a lot of markers on them that the immune system can identify. So there's a lot of various things. And then one of the other reasons is that these tumor cells express a lot of what we call immune checkpoints. So these are the ones that are basically putting the brakes on the immune system. So keeping an immune cell, like a T cell, from actually attacking the tumor. It's just like it's not got the brakes on. And so these PD-L1 and B7H3 are two of those brakes. And so the idea is that if you could potentially use inhibitors to these two brakes, could you actually improve the efficacy of this approach? And so this group was able to show that both of these markers are very highly expressed in glioblastoma cells. The expression is associated with worse survival, and they're basically able to demonstrate if you block that, then you can increase that immune response, and the immune system can attack the tumor. So that's a very interesting approach, not quite ready yet for prime time, but moving in that direction. Another one has relates to CAR T cell. So this is a specific T cell CAR T called B7H3. So sort of the same checkpoint that we just were talking about. And so this was a first in human phase 1 trial. So really just looking at safety. And these B7H3 CAR T cells were injected into the ventricular system of patients through a catheter, and looking to see if this was going to be safe or not. And basically, the group found that this was very safe to do. There was not a large immune in reaction, not a lot of inflammation in the nervous system that would have caused a lot of toxicity. So it was really well tolerated, and they're looking at efficacy. I don't have those data, but it's very, very interesting. So in the group, what they found was two partial responses, two stable disease, and then the disease control rate was 44%. So this is, again, it's encouraging, but still early stages. It's just the phase 1. So I think I just said all these things, but it is important to remember that using local therapy for something like a CAR T, which is being done in lots of other studies, is definitely feasible and safe. There were a couple of other studies. There's the eSync trial that we know about. So basically demonstrating that an academic center can create a CAR T cell and make an effective therapy. And that's also true with the B7H3 that I just mentioned. They did identify multiple potential mechanisms of resistance. I just thought I would sort of share some of those with you, which is really that although initially this therapy is very pro-inflammatory, very quickly some of those immune suppressive cells kind of come back into the tumor. So it's more of a transient effect. And there were upregulation of a lot of these immune suppressive types of cells, these what are called Treg cells, that also contribute to immunosuppression. And then even after treating, so we mentioned this B7H3 is highly expressed. Well, some of the tumor cells actually stopped expressing it, so it would no longer be an effective target for those types of cells. Not to go into a lot of detail, because I think we're almost running out of time, is the interest in developing liquid biopsies. So as everyone knows, in order to understand what's happening within the tumor, the current gold standard is to do a biopsy or to do a resection, and that's hard to do repeatedly. You couldn't do that once a week or even once a month. But there are liquid biopsy approaches that actually can do that. So there are some groups that are using cerebral spinal fluid through a lumbar puncture that can be done, daily even. And then other groups are looking at blood-based biomarkers. And so, I'm not going to go into any of these, but people are looking at it as a way of helping to identify the diagnosis, to look at predicting outcome, to look at response to specific therapies, to measure and to follow 2-HG, that oncometabolite. So lots of activity being presented across all of these different approaches. Our esteemed Dr. Hervey Jumper was invited to give a talk about the evolution of neurosurgical brain tumor care over the last 30 years. This was the 30th anniversary of the Society for Neuro-Oncology. So very timely presentation and really presented a lot of the advances that have occurred in brain mapping and awake craniotomy, which the UCSF team has really pioneered and made neurosurgery of brain tumors in very difficult locations to be safe, in part through the leadership of UCSF. There were also some health disparities and care access presentations. So this was the one that received the Health Disparities and Quality Improvement Award, and basically, looking at what are some of the challenges to access to trials, and testing, and also informed decision making. So some of the findings from the survey really was, as we all know, there are significant disparities in trial access. If you live in the Central Valley in California, there are going to be many fewer trials, if any, compared to someplace like San Francisco or the Peninsula. The same is true with molecular testing, not adequate, I would say, particularly given that first slide I showed you with all of those different boxes were demonstrating the importance of molecular testing in our diagnosis and also our treatment. Were gaps in informed decision-making support. We know, of course, that the rural populations are particularly underserved, and there are a lot of patients who probably are not offered really the best care options. So telemedicine has definitely helped. I feel that for sure. But there are still a lot of gaps in giving optimal care to patients, particularly in the community. So just last slide, conclusions and future directions. So precision medicine is a reality. It's not just IDH inhibitors. There are actually a couple of other inhibitors we didn't talk about that are being rapidly adopted in clinical practice and make a huge difference for our patients. There are multiple novel approaches that go beyond just radiation chemotherapy. So those would be things like the mitochondrial targeting therapy, immunotherapy, the rhenium 186 radiotherapeutic. So lots of things going on. Liquid biopsy is developing and becoming much more of a sooner reality than it currently has been in the past. There's a lot of focus, as we just talked about disparities and access. AI, as I mentioned, is becoming more and more an important part of not only our research, but really on the verge of being integrated into clinical practice. And then just lastly, we did talk a little bit about the molecular heterogeneity, looking at patients at the time of diagnosis and recurrence, and how that is a big challenge for us in terms of how we can provide more personalized care for patients. With that, I'd like to thank you and happy to take questions.
Great. Thank you so much, John. That was very comprehensive and really wonderful, um, uh, review for everybody, spanning so many different topics. And I think it reflects all the great work that's happening. So I'm going to go through some of the questions that were asked.
Great.
There's quite a few about imaging. So let's start off with one of them that talks about the fact that, and I think you showed this with the Indigo trial, that some of these tumors don't grow very quickly. They kind of grow slowly over time. So one question that came up was, shouldn't a radiologist be looking like at not just the last scan that was done, but go back and look at the history from previous scans? And is there a possibility of really using AI, as you mentioned, for that?
That's great. And it is always a really important reminder for slow growing tumors to look back over longer periods of time. And you're absolutely right. I think um, all of us are a little bit sort of here and now focused. And so we frequently compare, you know, the current scan with the most recent scan, which could be anywhere from 2 months to 6 months. And that is sort of how we have approached this. But you're absolutely right that if they're slow growing, you have to look back over years sometimes to see changes. And not only tumor growth, but even tumor response to something like an IDH inhibitor. That could take years to actually see that happen. I think the tumor growth rate change is going to help us to make that determination a lot sooner because that can happen within 6 months. You can see that. So it's not shrinking, but it's just not growing as fast. Um, but I think that that'll be really important. And then to your point about AI, absolutely. I think we will start to see that being integrated into the workflow more and more as we become more comfortable with it, as the radiologists become more comfortable with it, and as the models become more validated. So
Great, thank you. Another question about imaging. You mentioned about the axonal injury and how that might confirm, make progression worse. So one question that came up is whether there is any imaging technology that could sort of inform us about axonal injury.
that's a great question. I am not sure that I know of an imaging modality that can do that. We can tell sometimes on the flare image, the that can actually demonstrate the sort of dying back of the axons. There's something, don't remember this word. It's called Wallerian degeneration, and that can be identified on MRI scan, and you can basically see the injury of the nerves. Um, where there's been a disruption of that axon track. But aside from that, I don't know that there's a really specific way of doing it.
So you talked a little bit about some of the results of clinical trials that were highlighted at the meeting. There's a lot of information out there about the personalized peptide vaccine from Germany, from the CGAT group, and someone was asking if there were any updates on that particular treatment.
Good question. I don't think so. They published a paper last year, and I don't know. I don't remember if I presented that last year. But right now, they're continuing to treat patients, but they're planning a clinical trial here in the U.S. with multiple centers to basically do something that's more randomized, so sort of more of a placebo control study, so that we can learn a little bit more about how effective the treatment is.
Great. So as you have talked about, a lot of these treatments are for recurrent glioblastoma because that's a very challenging situation when these tumors progress. And so one question that came up was, there's a lot of promise with these IDH inhibitors. So is that something that might be helpful for a glioblastoma patient if they're many, many years out?
So we don't think so. And primarily because glioblastoma does not have an IDH mutation. And so the drugs won't actually work in that subgroup of patients. Um, I'm not aware of any tumors gaining that mutation. We do know that those that are IDH mutated at diagnosis will remain IDH mutated sort of pretty much forever. But I don't know of the reverse happening where a tumor gains one of those over time.
Yeah, the only other thing I would say is that, if the patient was diagnosed a long, long time ago,
Mhm.
the diagnosis of glioblastoma is different now. So an IDH mutant grade 4 tumor in the past was called glioblastoma. That's not what it is now. So it's worth it to get the tumor retested to see if possibly it is an IDH mutant tumor.
That's
Would
a
you?
really good point. Yes. Yeah. Thank you.
Yeah.
That's really important.
So that's just something to consider.
Yeah.
You talked about a lot of research trials. One of the questions that came up is, as a patient, are we expecting our providers to tell us about these trials, or do we have to go out and seek it ourselves and try to figure out what's right for us as a patient? That's one of the questions that came up.
Yeah, I get asked this question a lot in clinic, and I think it's a combination of things. Obviously, you should talk with your neuro-oncologist about what is available and where those things are available. What they're excited about, to help explain some of the nuances of those types of studies. Um, but I also believe, that patients should be their own advocates as well. And getting second opinions is usually worth the effort, and even reaching out to some of our brain tumor related foundations. There's the National Brain Tumor Society, the American Brain Tumor Society, or, yeah, American Brain Tumor Association, sorry. And many of those groups have sort of nurse navigator trial sort of groups that can help you identify interesting studies.
So, you talked about some cellular therapies like the CAR T therapy, in NK cell therapies. One of the questions is being asked is whether there was any discussion about dendritic cell therapy at the conference. Is this available in the United States? What's the status?
I don't remember any dendritic cell trials presented, but there are definitely some active groups, and UCLA is one of them, where they have a dendritic cell program, testing new combinations and that sort of thing. But I don't remember seeing. I could go back and look. I don't remember.
Okay, that's great. So this question isn't necessarily, tumor related, but obviously, whenever we think of axonal injury and the effects it has on patients, in terms of perhaps like cognition or other things, could that worsen like Parkinson's or some other degenerative disease because of the axonal injury? Is there any information about that?
Great questions. Boy, this is a really good group. Um, I think that that's a really, really interesting question to ask. Are patients that have Parkinson's disease more likely to progress faster or to have tumor spread into affected areas? I think those are really interesting questions, and I do not know the answer to that, but I would think that theoretically, yeah, maybe that is actually um, you know a confounder there.
Okay, and those were great questions, everybody. I'm going to wrap up with one last question for Dr. De Groot. In terms of what are you most hopeful about for glioblastoma patients? So in the next few years, what drives you to say, what, this is going to make a difference, and we're really excited about things.
Well, I think I have the same answer every time I get asked. I think that the most interesting things are related to immunotherapy. Um, and I think we have a lot of work ahead of us. But I, I look at some of the other types of tumors where we see cures in patients with, stage 4 melanoma. And that is just so inspiring, and really makes me think that if we can get immunotherapy to work, that's going to be what makes a really big difference. So there's lots of different approaches, as you heard about today. There's the CAR T cells, and there's other NK cells, and there's checkpoint inhibitors, and there's lots of different types of studies, and I don't know which one is going to really make the difference. But there's so many really, really smart people at UCSF and lots of other places that are gonna figure it out.
So I want to take this opportunity now on behalf of all of us here to thank Dr. De Groot for spending the time with us. I think it was a wonderful overview and really inspiring to all of us. I want to thank again Naomi and Lacey and Joni and Mary for hosting. and again, the Suri Sobrato Survivorship Program for giving us the opportunity to have these types of really engaging, I think, and it really reflects how you guys were listening. So that's wonderful. So thank you all again, and I'll hand it back over to Lacey. Thanks, John.
Great.